Dear ESTS members and webinar attendees, my name is Lieve de Pieperen. I am thoracic surgeon at the University Hospitals of Leuven in Belgium, and I'm a member of the Learning Affairs Committee and responsible for the webinars in the ESTS. Last month, we had the first webinar in a new series of webinars launched by ESTS about mediastinal staging with Paul Delane as a guest speaker. We had over 200 registrants and 85 people have watched the replay. So today, it will be about sublobar resections, and I'm very proud to introduce you to Professor Dominique Gossot as a guest speaker. He is the head of the Department of Thoracic Surgery at the Institut Mutualiste Montsouris in Paris. He's one of the leading thoracic surgeons in Europe concerning advanced minimally invasive lung surgery and anatomical segmental resections. He has written many publications on this topic, and he's the author of the famous textbook Atlas of Endoscopic Major Pulmonary Resections. And at the beginning of this year, he was hosting the first international conference on sublobar resections for lung cancer. Please, Professor Gossot, the stage is yours.
Okay, good evening, everyone. So first, before starting, of course, I have to give my disclosures. So I'm a lecturer for Medtronic Company. Our department is an expert center for endobronchial navigation, and I'm consultant for an instrument manufacturer company. So I think a good introduction to this presentation would be to have a quick poll about the indication of respective indications of wedge anatomical segmentectomies and lobectomy for stage 1. So Lieve, maybe you can ask the 3 first questions.
Okay. So the first question is launched according to the 2003 ACCP guidelines. What should preferably, or how should, I cannot read this very well. A stage 1 non-small cell lung cancer carcinoma, I'm sorry, should preferably be treated by 1, a wedge resection, 2, an anatomical segmentectomy, or 3, a lobectomy. And then the people can vote. So for the ones who have not done this before, at the right sidebar, you have questions, polls, and people. So the middle one is polls, and there you can vote on what you prefer. So right now we have 21 answers, already a little bit more. 66 people are attending, so we should have a little bit more. I'm just waiting for another 5 seconds, but I think it's going to be quite clear here. We have 10% wedge resection, around 15% anatomical segmentectomy, and all the rest of the attendees are choosing for a lobectomy. Are they right, Professor Gossot?
Yes, obviously, according to the guidelines, lobectomy so far is still the standard. So the ones who have voted 3 are right. So we can move to the second question. Lieve, maybe you can give it, or you prefer me?
I'll give them the second question right now. So according to the most cohort studies, 5-year survival after sublobar resections for stage 1 non-small cell carcinoma is 1, superior to lobectomy, 2, equivalent to lobectomy, or 3, inferior to lobectomy. And people are already starting to vote again. There no one is thinking superior. And we have 3/3 equivalent and 3/4 equivalent and 1/4 inferior to lobectomy. Who is right in this question?
Well, I'm sorry to say that according to the cohort studies, especially the one published in 2011 based on the ACCR on 14,000 stage 1 lung carcinoma. It was inferior to lobectomy, even for T1A.
Inferior, so we're definitely here to learn something today.
And so we can move to the third question.
Okay. And the third question is, according to most unicentric studies, 5-year survival after sublobar resections for stage 1A non-small cell lung carcinoma is, again, the same question, superior, equivalent, or inferior to lobectomy? And there people are voting quite similar as to question 2, I have the impression. We go to a little bit more equivalent, even one
Yes.
daredevil saying superior.
Yes, so they are right. It's, according to unicentric studies, it's equivalent.
Okay. So I guess we go back to your presentation then.
So do you have it?
Okay, yeah, perfect.
Okay, so you have seen that in multicentric studies, lobectomy is still considered as the gold standard. So I think as an introduction, I would like to stress what has led us to reconsider the role of sublobar resection for early stage lung carcinomas. First point is that the profile of our patients and of their tumors is changing with more and more T1A tumors and ground glass opacities. I think also that in 2018, surgeons are more and more concerned by the morbidity of what they are doing. Mm-hmm. And as you know, the morbidity of lobectomy is extremely high, around 40% in most studies. So surgeons are also concerned by sparing lung function. And finally, they started to have questions about the supposed poor results of sublobar resections. We will see that into detail in a few moments. And I must say that the alternate treatments that are forthcoming may play a role of the sudden interest of surgeons for sublobar resections, because we are seeing new treatments that are arriving with good results. Mm-hmm. So what we will discuss this evening is what are the indications in 2018. Of course, we are surgeons, so we are mainly interested in technical aspects, and I will give you some basic considerations. And if we have time, we will end up by an example, which I have chosen as a, let's say, medium difficulty, not very easy, not very difficult, a right apical-posterior segmentectomy.
Okay.
So let's start with the indications. Of course, we can split this in two main indications. Sublobar resection for some metastasis and for each one. Regarding metastasis, for a very long time, we had only the choice between wedge resection, when it was feasible, and lobectomy, or for some team, sublobar resections, but performed by thoracotomy. So it seems that sublobar resection, when performed by thoracoscopy, could be a very good compromise between wedge and lobectomy. And as you know, a wedge resection for some metastasis is not a good operation, because sometimes you cannot achieve satisfactory safety margins, and as shown on the right picture, you can observe some relapse. especially after metastasis from colonic cancer, because you have these cells, these cell clusters that are far away from the main tumor. These are examples of solitary metastases that obviously are not removable by wedge resection. And I think the choice cannot be a lobectomy for these lesions. So sublobar resection is an excellent alternative treatment. Mm-hmm. Second indication, of course, early stage non-small cell lung cancer and some granulopathies. So I think that regarding T1 tumors, the debate has been for a long time polluted by the famous publication of Robert Ginsburg with the lung cancer study group. Most of us know this publication, maybe not the younger attendees of us, that concluded that lobectomy should remain the gold standard for treating T1 tumors. The issue with this publication is that it was a multicentric studies. It was mixing wedge resection and anatomical segmentectomies. So there were many bias in this study. However, if you look at publications that were released later, like that one, it appeared that when you look at lobectomy versus for stage 1 adenocarcinoma and squamous cell lung cancer, the survival was better after lobectomy than after segmentectomy. And this was true even for tumor less than 2 centimeters. So the recommendation of this study was to keep with lobectomy, which was still considered as the gold standard. This was just a couple of years ago. Now, what is very strange is that when you look at the publications coming from, let's say, expert centers in Japan, you have excellent results that are published, and segmentectomy is never significantly superior to lobectomy, but it is at least equivalent. Mm-hmm. For instance, in this publication, in that one, and this was also the case in our series that is just ready to be released in the European Journal, when we had lobectomy, segmentectomy for T1A tumors, we had no significant difference. So what is wrong? I mean, why we have so many differences between multicentric study and unicentric studies regarding this topic? I think if you want to have a good idea of the problem, you can have a look at this publication that was released a couple of weeks ago in the Annals of Thoracic Surgery, comparing lobectomy and sublobar resection for stage 1A. So what is written in this publication? It's written that you have a similar overall survival for lobectomy and sublobar, but a much higher risk of recurrence for sublobar. If you look at the data of this publication, there are, however, some problems, which are these ones. You have much more lobectomies than sublobar, and in the sublobar group, you have mainly wedge resections. Now, if you look at the lymph node dissection that was performed during this operation, you see that the median lymph node count was 7 in the lobectomy group, which is, let's say, poor, and 1 in the sublobar group, which is extremely surprising. And the margins were positive in almost 7% of the operations. So needless to say that this kind of study is not very much acceptable, and that you can understand that there are many recurrences. I give this example because I think it clearly shows that we are not talking about the same things when we are comparing lobectomy and sublobar resection. And I think the issue is that most of us in these audience probably do a lobectomy rather in the same way, while we don't perform a sublobar in the same way. And so I think this webinar probably is very useful to know what we are talking about.
Yeah.
So is it oncologically valid? I think we still don't have the answer. We have to wait for the ongoing trials. Probably you have heard about these trials, one in the US and one in Japan. The answer is awaited in 1 or 2 years. Waiting for the answer of these trials, we have to say that lobectomy in studies have slightly better results, but not in expert centers. Have questions, we can move to the technical aspects.
Okay, I will ask to the audience. So already 82 attendees right now. For questions, you can also go to your right sidebar and you can ask them to us. Then they come on our screen, and I'll try to translate for everyone and try to ask these questions. So please, if you have any questions about this first part, you can ask questions by typing it in your right sidebar under the title questions. I don't think right now that there are any questions yet, so maybe we can come back on that a little bit later. Okay.
As an introduction to this second part, I have to say that you have asked me to give this webinar. Mm-hmm. So obviously, I will explain the way we are doing these operations in our institution, and probably you would get another point of view from different hospitals. So I cannot escape this by, I would say. I will describe the way we are doing it in our hospital. Mm-hmm. So the points I will stress this evening is how to prepare these operations, how to do the setup. We perform an operation that is so-called Fisher-based, so we will see what it means. How to expose the elements. I have had a part on suturing because I think in many of these operations you are more or less obliged to master thoracoscopic suturing. An important part is lymph node dissections, safety margins, and of course how to deal with the intersegmental plane. So let's start with the operation. I suspect that my friend Masaki Sato is not attending this webinar from Japan, but if he would give this talk, he would probably say that thoracoscopic segmentectomy is nothing less than 3 steps. First step, preparation. Second, preparation. Third step, preparation. And I think he's right. So preparation means that you have to be prepared to load the tumor. You have to be prepared to the anatomy you will face during the operation. And if possible, prepare the margin resections. Before starting, I would like to show you just this short clip. I show it to you because many of our visitors are surprised when they see that. So obviously, if you are dealing with sublobar resections, you deal with small tumors, and sometimes you don't have a preoperative diagnosis. So I think you should avoid a wedge resection, especially if you remove only one segment, because for the pathologist, it will be a big mess, very difficult to examine. So you should preferably do this way. Use the needle that are used by our friends, our radiologist friends. We are doing this for many, many years, and the yield is excellent. Mm-hmm. Now, coming back to the preparation, why we have to localize these tumors? For two reasons. First reason is that, as you know, some tumors are not localizable, like pure GGO, of course, you know this. And also because some lesions are at the frontier of two segments, and it's interesting to know it before. So during many, many years, we have used this kind of techniques. Some surgeons still use this technique using a hook wire placed on the CT scan. You can combine this with a methylene blue, which gives you this kind of picture. As you know, it has some drawbacks. The patient has to go to the CT scan and to the operating room, so there are some logistic problems. And also for the patient, it's not always very comfortable, and there are patients. So now we use ENB like this, which gives you this kind of pictures.
Okay.
The second reason for using or having a preparation is to look at the anatomy, which, as you know, is highly variable. So we use reconstruction, 3D modelization, and it works like this. So we send the CT to a company that give us in return the modelization, and all the members of the team have the model on their laptop, on their smartphone. And as you see on the right-hand picture, we have a huge display in the operating room, so we can refer to the modelization during the procedure. So let me explain to you briefly why modelization is very helpful. Look at this picture on the right, and figure you are performing a partial segmentectomy of the basilar segments. You see that the vessels have been dissected in a rather good way, but you are not able to understand the direction of the vessels. Of course, for the artery to segment 8 is more or less obvious, but for the other one, you don't know exactly. So if you perform just a segment in 9-10, you will be in trouble to decide which artery you have to divide. If you have a kind of map like this, it becomes much more obvious. So I don't say that modelization is absolutely necessary for any type of segmentectomy, but for all the complex segmentectomies, especially for the basilar segments, it's, in our point of view, almost mandatory. Mm-hmm. The third reason to use a preparation is to have an idea of the resection margins. It was described by a Japanese surgeon, Shingo Iwano, in 1 or 2 years ago. As you know, if you look at the guidelines of the ECCP, it's recommended to have a safe margin, which should be greater than the maximum diameter of the tumor. So we have asked the company who is doing this modelization to calculate the safety margin. It's represented in pale yellow, as you see on the right picture. So let me give you a few examples. On the left side, you have 2 examples of planned segmentectomy. You have the nodule in green, the safety margin in yellow, and you see that if you remove just one segment, the safety margins will probably be safe. Here on the right side, you have a few examples of a tumor that is at the frontier of 2 segments, And probably in these cases, you will have either to enlarge the planned segmentectomy or to remove 2 segments.
Mm-hmm.
Now I move, except if you have any question on this modelization, I move to the setup. So our setup is to use a high definition imaging system. We are working with a deflectable scope. We don't have a cameraman, and this for at least 15 years of doing this surgery. I have always used a scope holder. We have dedicated instrumentation. We use a multi-port technique, energy devices, and we staple the intersegmental plane.
Okay.
So by deflectable scope, I mean this scope that most of you know probably, which has some drawbacks like being expensive and fragile, but on the other hand, it works extremely well. It gives a wonderful picture. And the second generation has an integrated fog-free device that is very useful. As this procedure can last rather long, we very basic trocar, extremely simple, that deflects the blood very efficiently. I show you this because with these 2 devices, you can operate during 3 hours without removing the endoscope.
Okay.
And as the scope holder, we use either a mechanical scope holder or this robotized scope position. While we're using dedicated instrumentation, I don't want to advertise it, but just to mention that if you have instruments that are developed for this type of surgery, you can have much more accuracy than with, let's say, other general laparoscopic instruments that many of us are borrowing to our colleagues from, for instance, digestive departments or so on. These instruments can be small, 5 millimeter or 3 millimeter. So we are using multiple ports. I will not, here it's not the place to defend multiple port compared to single port or 2 ports, but I just want to mention these 2 publications. I fully agree that this is not a major issue. We are in most cases dealing with lung cancer, and the goal is to cure the patient, whatever the number of ports you are using.
For sure.
What I want to mention is that this debate about a single port or multiple port is wrong. In my mind, it's false, because if you look at these pictures, you can see that with small diameter instruments, the damage to the intercostal space can be very. So we are using a fissure-based approach, and I think this is mandatory, maybe not for lobectomy, although I think it's preferable, but for segmentectomies, I think it's mandatory, especially if you don't have a preoperative modelization, because it gives you a better idea of the direction of the vessels, and it's the only way to detect anatomical variations. Mm-hmm. This should be done for arteries and for the veins. As you see on this picture, you can get these pictures. I think you will agree that it looks very much like an anatomical book. So let me give you a few examples of why it's necessary to dissect extensively in the fissure. Let's presume that you are performing a basilar segmentectomy. You have the artery to segment 6. And if you are happy with the discovery of the basilar trunk without dissecting the fissure, you will probably staple the basilar trunk here. And if you do that, you will cut in the same way the lingular artery, which raises at a very low level on the basilar trunk. Mm-hmm. So you should not do this. You should do this, of course. Another example, same example, with the lingular artery arising very low on the basilar trunk, like this. And of course, you should not do this, but this.
Yep.
Another example. And similarly, if you perform a lingulectomy, which is supposed to be an easy operation, it's not always that easy. If you staple the lingular artery here, you will damage this artery to segment 8. So you should move like this.
Lobectomy, you would have a problem there.
Please?
Even in a lobectomy, you would have a problem there because it's going to the lower lobe.
Of course, this is also why we are defending a fisher-based approach for lobectomies, as William Walker will do. And I think, of course, even for lobectomy, it's very important to detect these variations. Mm-hmm. Now, I think exposure is crucial, and this is a reason for us to use multiple port. Maybe that for some of you it's obvious to help the use of loops, but maybe for the one who are not very familiar with the thoracoscopic major pulmonary resections, it's not that obvious. So this picture to show you that if you use these loops, it helps a lot for exposing the arteries. One or two years ago, we were using this this device from Ethicon company named Goldfinger. It has been removed from the market. It was helpful as a loop. So now, because we don't have this device anymore, we have developed our own Goldfinger, which we call in the department the Goldfinger of the pro surgeon. That is very helpful. For exposure, you can use also 3 mm grasping forceps, as on the left picture, or this on the right that we call throw-off instruments. They are grasping forceps that you can release inside the chest cavity. You put a thread on each, and then you just pass the threads through the chest wall, something like this. Mm-hmm. If there is no question, I go on. So why we think you should master thoracoscopic suturing and have the equipment ready in the operating room, because you can face two different situations. One is the situation where you don't have the room to pass a stapler. And one is the second situation is when you have to perform a bronchoplasty. So here, in this case, we are performing a segment 3 segmentectomy in a lady who was not very tall with a small chest cavity. And I have just made a summary of the recorded pictures, but you will understand that it was not possible to staple that B3 bronchus. So we could dissect it, mm-hmm. But after 10 minutes, we could not find any direction for the stapler. It was not possible, even with the loop, as you see here. So you will not transform this procedure because you are not able to perform a manual bronchoplasty as you would do via open surgery. So you have to do that manually. So you must have an endoscopic sorry, an endoscopic knife, and everything to suture.
Okay.
The second situation is when you are dealing with this kind of carcinoid tumors, with an excellent indication for sublobar resection. In many cases, there is no need to perform a lobectomy, especially for the typical carcinoid tumor. And sorry, again, can you hear me if I cut the sound?
Yeah. That's perfect.
Okay. Sorry. Okay. So I moved to the sound. This is another example of a large carcinoid tumor of B6 seen on the modelization. You see how big it is. So this is the B6 bronchus. And we have cut the bronchus with a frozen section on the margin and then suture it. Another example here. Okay, this is a summary of the way it works. So in another patient, so cutting the bronchus by hand, analyzing the resection margins, and then suturing it. And you see on the left side of the picture, this grasping forceps, that's for, we usually use extracorporeal knotting. Maybe some of you would prefer a running suture. I think it's up to you. It depends on what you master the best.
The question here is, what do you use for material? Do you use PDS, I think?
Yeah, PDS 4.0 usually, yes.
4.0, yeah, okay. So resorbable, long-lasting suture for 4.0, okay.
So we now switch to the issue of lymph node dissection, which is crucial in our opinion. And I would like to give you an example. Very recently, a member of my team was attending a meeting about the setup of a trial comparing sublobar and SBRT. And the question was lymph node dissection. And most of the men attending the meeting said, why you are performing a frozen section on intersegmental lymph node dissection? We have no time to do that. Well, I think you must find time, because if you don't do that, you will probably expose some of your patients to a recurrence and not perform the good operation, which sometimes can be a lobectomy. So it was demonstrated in 2011 by Wolf and co-workers that if you perform a segmentectomy without lymph node dissection, the results were not good, but the results were equivalent to lobectomy with a lymph node dissection. And in the GTO, a similar study was published 1 year ago. You see that on black is sublobar with lymph node dissection, in red lobectomy, and in blue segmentectomy without lymph node dissection. So for this, I think that an energy device like this bipolar, which can be either NSIL or Sonosurge, not Sonosurge, the one of Medtronic, Ligasure, is extremely helpful. This is an example where you want to perform a segmentectomy S2 on the left upper lobe. You discover this lymph node between the two arteries. I think you are obliged to analyze this lymph node. If it's negative, of course, you go on. If it's positive, you have to transform the planned segmentectomy to either a trisegmentectomy or to a left upper lobectomy.
I get a question here, Professor Gossot,
Yeah.
that this approach seems to be based on arterial anatomy, and the question is if the venous and the bronchial anatomy is as important, but I think you will dissect them as well, huh?
Of course. Yeah.
So you will take the artery, the bronchus, and the vein of that specific segment separately, of course.
Yes, of course.
Yeah. Okay.
Dissecting the lymph nodes is very important from an oncological standpoint, but it is also important to have a clear exposure for the dissection of the bronchovascular elements. This is a picture from the book of Nomori and Okada showing the lymph nodes at the basis of B3 and B2. And so this is B3, and here are the lymph nodes that are described in the atlas. And you see that once you have removed the lymph nodes, the dissection of B3 is much better.
Mm-hmm.
An example that we gave in our publication that was released some month ago in the Annals of Thoracic Surgery about unplanned procedure. So this is a lady who had this small adenocarcinoma in segment 8. So because this patient has a poor function, we had planned to perform only a segment 8 segmentectomy. So we start. So this is how the tumor looked like.
Mm-hmm.
And during the dissection, so we find this lymph node that really looks benign between the artery of segment 6 and the basilar trunk. We removed it, sent it for frozen section, and it was positive. Mm-hmm. And frankly speaking, I didn't believe it. When the pathologist called in the operating room, I said to him, "It's not possible, you must be wrong." And he said, "We were too examining this lymph node, and you can trust me, it's positive." So we switched to lower lobectomy. So in this publication, we had 3 invaded lymph nodes at frozen section. All of them were converted to a lobectomy. Same problem with the safety margins. Of course, it's obvious that all of us know that if you have short margins, you increase the risk of recurrence. So what we do is that, of course, we cannot ask the pathologist to examine all the staple line. So we just put 2 stitches on the part of the staple line we want to examine. So mm-hmm. Are these small tumors, and here are the 2 stitches on the staple line, and this will be examined by the pathologist. So again, coming back to this publication.
Maybe about the margin. The question was, or 2 questions here were: stage limitation for segmentectomy. How big can a tumor be? If you have a tumor of, let's say, 3.2 centimeters, will you do a segmentectomy or not?
So it's a different question. I mean, according to the guidelines, the safety margin for tumors less than 2 centimeters should be at least equal to the maximal diameter of the tumor. So it means that theoretically for 1 centimeter cancer, you must have at least 1 centimeter margin. And the guidelines of the ACCP say that if you have a tumor more than 2 centimeters, you must have at least 2 centimeters, a tumor of 3 centimeters, at least 2 centimeters. If possible, more than 2 centimeters. So to answer your question, if we have 2 centimeters tumors, usually most of these patients have a lobectomy and not a segmentectomy. But as you know, there are exceptions. I mean, you have patients with a 2 centimeters 2 centimeters tumor who have a poor pulmonary function or who had undergone a lobectomy 4 years ago. And for these patients, even if lobectomy is more oncological, we will prefer segmentectomy.
Okay, the question was in lesions with partially solid, partially GGO. What margin do you take then? If you have more GGO, does it also have to be like the largest diameter of the GGO, or just the solid part? Or is it something you...
Of GGO, but I would say that if it's really a pure GGO, we would not matter so much. But if it's a mixed GGO, we will consider it as an infiltrant, invasive adenocarcinoma, and act the same.
Okay. Based on the largest diameter then?
Yeah.
Okay.
The largest diameter of the solid part.
Mm-hmm. Of the solid part, yeah.
So in these publications, we had 7 patients with a frankly invaded margin or a suspicious margin. And what is very interesting is that in some of these patients, the surgeon was sure the margin, and the answer of the pathologist, it's suspicious. So it's another argument to have a frozen section of the margins. And as you will see, in 7 of our patients, we were obliged to convert to a more important resection. So what does it mean? It means that in 10 patients of this series, maybe we have avoided 10 recurrences, which is of course better for the patient. But if we haven't done this, we would have underestimated the results of our segmentectomies, because these patients, they must have a lobectomy. So of course, it takes a little bit of time to perform this frozen section, but if we want to make an appropriate operation, we have to do this. So again, I showed these pictures already.
Mm-hmm.
So if you don't have any question, I move to the last part, which is how to deal with the intersegmental plane. For a very long time, it has been a major concern for us, maybe the most difficult part of the operation. It's becoming a little bit clearer. First important point, before dividing the intersegmental plane, you have to dissect the stump of the segmental bronchus to keep it away from the staple line, something like this.
Mm-hmm.
If you don't do that, you will have a problem with the stapler. So most of the surgeons, and we did this way before, are using an inflation-deflation line, something like this. So this is the removal of segment 6 of the left lower lobe. So this is the deflated segment 6 and the inflated basilar. Very recently, we were obliged to use this inflation-deflation technique, and this on a basilar partial segmentectomy. This is to show you that sometimes it works, but usually in our experience, it doesn't work very much. Mm-hmm. One word about selective bronchial insufflation. What does it mean? It means that you can open the segmental bronchus, insert a catheter inside, and when we were using this, we were were doing this, we were using a catheter that was developed for cholangiography. So there is a small balloon, so you can insert the catheter in the segmental bronchus. You inflate the balloon and then inject air like this. We have given up with this technique for several reasons. First reason is that it's not very precise, and second reason, complications have been described. So the reason it's not very precise is that you never know whether the catheter is really inside the segmental bronchus or has not moved into a subsegmental bronchus, and in most cases it goes into a subsegmental bronchus. And the other reason, as I told you, is that there are some complications have been described. So let's take the example of the posterior superior segmentectomy, segment 1 and 2 on the right side. This is how it goes with the inflation-deflation method. And you see how nice is this remaining segment 3. But you can also understand that it's not very easy to deal with the inflated lung. So this is how we did before. And this is how we do now with the infrared imaging system using indocyanine green. So frankly speaking, it has changed our life. So here the picture maybe doesn't seem very good. But I can show it to you on another example. So for this, you need a dedicated camera system, a dedicated optic. We use indocyanine green injected intravenously at the dose of 0.3 milligram kilo. And because we don't use the same system for the marking and for the rest of the operation, we switch to our deflectable scope for the rest of the operation. So we put these coagulation dots like this. The results that have been published so far with this technique range from 85% to 100% of success. I would say we are around 90%. We have some failure and we don't exactly understand why. One of the reasons is COPD like this. So in this lung, it seems as the capture of the indocyanine green is not very good, and there are also some anatomical variations. I can show you this example that we have published on CTSNet a couple of weeks ago. So this is a patient who underwent a basilar segmentectomy. You see on the right side that the anatomy cannot be clear. It's extremely clear. And so we inject indocyanine green and expect to have a straight line between segment 6 and the basilar segments. Actually, this is what we got. So we were surprised, moved to the reconstruction, and see that we missed this artery, which is unusual, coming from A6 to the basilar arteries, which explain. So I think this is a good example to show you that this method is usually very accurate. Another application of this technique is that sometimes, even if you have a modelization, you are not very sure of the direction of the arteries. For instance, this artery looks as an artery to segment 8. Actually, it was for segment 7. And we did not clearly understand during the procedure. So in 2 or 3 cases, we have used these bulldogs to clamp temporarily the artery, inject the indocyanine green, and see that you see here the segments to be removed. So it makes you feel more confident sometimes. One word about stapling, last part of the presentation. So as you see, some surgeons still think that stapling is not a good method because when you do that, you are losing valid parenchyma because you are doing some plication, remaining segments. Mm-hmm. There are actually many publications, especially experimental ones, that shows that this is not true. So, of course, you can have sometimes this aspect with a plication of the lobe, but it's very difficult to say that you will lose a lot of respiratory function because of this plication. And in most cases, you get this satisfactory result as on the right side. I cannot go into the details of this study because we are just in the way of publishing it. We have just finished, we submit it very soon. But we have made a study based on CT scan performed 3 months after a segmentectomy to see how looks the remaining segments. So sometimes it's not very good, like you see here, this partial consolidation of the remaining segments. But in most of the cases, it looks like this. And probably the drawback of stapling in this patient is minimal. Mm-hmm. However, stapling it can be very, very, it's not difficult if you have what Masaki Sato called linear or V-shape like this. But on the basilar segment, because of the pyramidal shape like this, it can be very difficult. And we got a lot of problems until we understood that our mistake was to, first of all, in the beginning, we didn't have infrared imaging system, so that makes things difficult. But the mistake we were doing is that when you do that, you are at the end of the operation after 1 hour 30 or 2 hours, and you say, well, it's the end of the operation. I just have to staple it. Give me the 60 millimeter stapler, and in 1 or 2 shots, it will be finished. No, I think it was a mistake. It's much better to do this with short reloads, like 30 or 45s, and progress step by step. Of course, probably it's more expensive, but it is much more precise, and it can give you this nice picture after segment 9 and 10 in this patient. So you have segment 6, you have the middle lobe here, the segment 8, and here the staple line. Yes, this is just to show that you don't have to staple in 1 or 2 shots. Do that step by step. So I realized that it's almost 55 minutes. So
it's almost 1 hour now. I would first like to ask the questions people were asking. We already had some in between. A lot of questions are about the 3D model. If you can just find this, but this is available by a company, I think. Yeah.
Well, you have more and more companies providing this kind of services. Mm-hmm. We are working with a French company named Visible Patient. You have other possibilities on the market. For instance, the one of Fuji, Synapse 3D, and there are other developments ongoing. So I will not.
Different options, I think there. Yes. Another question was about cutting the vessels. Do you use staplers or energy devices?
We use a combination of clip applying and energy device, vessel sealing device.
Okay.
We don't trust clips. We don't fully trust vessel sealing device, so we use both.
Okay. And another technical question was the port placement. Is this different according to what kind of segment you attack, or is it always the same approach?
Well, this is a question we always have with our visitors. Where do you place ports for an upper lobe or a lower lobe? Or the answer is always the same, is that for any of these operations, we have to perform more or less the same lymph node dissection. We can face adhesions in the upper part or the lower part of the chest, so we have to be ready to work in the whole chest cavity. So it's always the same.
Okay. Then I come immediately to indeed the next questions. So we saw that the in-one lymph nodes were very important, and you take a frozen section on that. There were quite some questions about that. So do you always perform these frozen sections, or is this just depending on patients? For instance, there was a question, a patient was scheduled for segmental resection, can probably not undergo a lobectomy. Do you perform a frozen section then, if you already know that you will probably not go as far as a lobectomy?
No, obviously, if we are sure that the patient cannot tolerate a lobectomy, we don't, of course. If it does not change the resection, we don't. But in most cases, we prefer to a lobectomy rather than taking a risk of positive lymph node in place.
Okay. And then about the in-two nodes, what do you have to do for lymph node dissection in segmental resection? Is this the same as in a lobectomy? Do you perform on the right side 2, 4, 7?
Yes, absolutely. Yes.
Okay.
Yes.
Because I think that's also an important message. If you compare this to the wedges, this is really a difference. Huh?
Yeah.
So in all segmental dissections, you perform in mediastinal lymph node dissection.
Yeah, what we call a true, or you could say a radical lymph node dissection. I must say that in elderly patients, when we are sure that this patient will not have adjuvant chemotherapy, if it's positive, we don't. But in this case, we say precisely in the surgical report, the procedure was done without lymph node dissection.
Okay.
So that it's precise and the patient can be stage NX.
Yeah.
Otherwise, if we don't perform sampling, we perform either no dissection or a radical lymph node dissection.
Okay. Do you have any age-dependent criteria? In a 60-year-old patient or an 80-year-old patient, is this something that is differing or not?
You mean in terms of what, of lymph node dissection?
For instance, yes.
Yes, so yes, it changes, of course. As I mentioned, if it in an 80-year-old patient probably will not have an adjuvant chemotherapy, so it may make us decide in our meeting not to perform a lymph node dissection, but it's quite rare. It's quite rare.
Okay. And then another question coming from the quite extensive lymph node dissection. Do you often see skip metastasis? So the in-one nodes that are actually negative, but your in-two nodes are positive in a segment.
Frankly speaking, I didn't study this in detail. I could not answer that question, but I would say probably yes. There are some cases probably.
Looking if there were some other questions. Another one was, is segmentectomy always necessary in lung metastasis? Don't we have to do any wedges anymore in metastasectomies, or what is your opinion about that?
No, it was not my message. Of course, each time we can perform a wedge resection for peripheral metastasis, we do it, of course.
Okay.
Provided we can achieve satisfactory margins. But on the example that I have shown to you, every one of us knows that sometimes the metastasis is deeply located inside the lung, and it's not possible. So should we choose a lobectomy in these patients? I don't think so. So we prefer a proper, well-done segmentectomy than a poor wedge.
Okay. Coming back on the lymph node dissection, you said if the patient is not able to have any adjuvant chemotherapy, then we will probably not do this. But the comment on this is, okay, your patient can probably have radiotherapy. So maybe.
Maybe if you think, well, probably a matter of philosophy, but yes, I do accept this this opinion. Yes, it's true.
Okay, and a technical question about this port. If this is commercially available, but it is, I already have seen this. This can also be found. I don't know what company it was, but it.
You mean the deflectable, the drop deflective trocar?
No, the port with that is a little bit coverage for the drip off of.
Yes, with this kind of skirt. Yes, this is something we have developed and it commercially available by the company doing our instruments.
Okay. I think these were questions up till now. We are having already 1 hour, 7 minutes. If people want, we can go to a practical application. I will just send out a poll and then we can see what we are going to do. Do we still have time to see segmentectomy or not? I would say people can vote. And it seems that at least already 15 people are interested. So yes, we can go on.
Okay, so some courageous people. So I've chosen this segmentectomy because I would call it medium difficult. It's not very easy, but it's not very difficult. And this is a segmentectomy we are very frequently performing in the department. And when you will see the picture, probably you will understand why. So when you have this kind of lesions, you can, rather than performing a lobectomy, you can do any of these procedures depending on the location of the small tumor. Multiple ports, and we are using more or less the same approach as we do for a right upper lobectomy. We do it totally reverse compared to what most of us are doing, who are approaching from the front. So we approaching from the opening the fissure, control the ascending A2, then the bronchus, then the branches of the trunk, and then the vein. So what are the anatomical landmarks? Although it's called segment 1+2, usually bronchi are independent. So this is an example where you have a true B1, B2 trunk, but usually it's more like this, B2, B3, B1. And even a couple of days ago, I had faced this variations I didn't know. B3, B2, and 2B1, one independent and one arising from B3. This is the usual arterial pattern that you know, A1 ascending A2, and sometimes you don't have any A2 in the fissure, and it's very nice to see it before, so it avoids you searching during 20 minutes, where is this ascending A2? It's simply, sometimes it doesn't exist. Of course, you have to know the variations. You have very frequent a common trunk between A6 and ascending A2, sometimes an artery for segment 3. And of course, what Nomori and Okada calls the recurrent A2, which is extremely frequent, which can be retrobronchial or pre-bronchial. And it looks like this. So this is when you approach an upper lobe, right upper lobe from behind. Once the bronchus has been divided, you encounter the branches of the trunk, A1 and A3. And when you have a recurrent A2, it looks like this, A1, A3, and the recurrent A2 that you will have to control if you perform a segment 1+2. Regarding the veins, so you have the central vein in the fissure you have to control, and of course respect V3. You know this artery called V2 transversal that hides the view on the ascending A2, and you have to control it. Of course, take care if you have this variation with a huge vein in the fissure, you have to take care. You have also to know this venous variation called retrobronchial vein. It's a vein coming from segment 2 and draining into the inferior pulmonary vein, something like this. And this is another example. So I move to the technical steps. So we approach it as perform a right upper lobectomy, opening the fissure to make it if it's a thick and long one. So you can use either a vessel sealing device or a stapler. And once you have make the fissure shorter, you have a better view on the posterior mediastinum and pass this dissector like this, always keeping an eye on the esophagus. On the right hand side, you have clips that summarize the way it's done. So you open the posterior mediastinum like this. So you create a passage like this. Mm-hmm. This must always be done under visual control. And then staple it. And once you have stapled the fissure, the dissection of the ascending A2 becomes very easy. Like this. So it's easier to expose it once you have opened the fissure. Mm-hmm. Then you control the vein that hides the ascending A2. And sometimes you face this situation, instead of having one ascending A2, you have two arteries in the fissure. And sometimes you don't know exactly whether they are both for segment 2 or one for segment 2 and one for segment 3. So if this, you just control that one, keep this one and go on the dissection. And here you see that it's obvious once you have dissected B3 that this artery is also for segment 3. Mm-hmm. As I mentioned to you, you have to remove the lymph nodes. And so for this, we use this very nice device. We are using it for many years. It's a versatile bipolar forceps. You switch from the forceps to a scissor in one click. So this is how it looks like at the end, before division of the and of the bronchus. So either you staple B1 and B2 together, or if they are separate, you staple it separately. And I want to show you this sequence of pictures, because sometimes you don't know exactly which bronchus it is. Of course, it is obvious that this one is B3, but this one, especially if you have lymph nodes or fibrosis, you don't understand if it's for B2 or if it's a common trunk for B1 and B2. So don't be afraid of this. Go on with the dissection. Here now we have dissected the recurrent A2. We still don't know exactly what is this bronchus. We dissect the first one we encounter, staple it, and we see B1 behind. So we will staple it in 2 steps. It's not a concern. This is to show you that sometimes it's even more difficult. We thought that this was B1, but it was not B1. It was a branch of B1, and we had to restaple the bronchus here.
Okay. Then
we divide the A1 artery, or A1 and recurrent A2 if recurrent A2 is present, and then the vein in the and in the V1 in the mediastinum. And then move to the intersegmental plane, as I showed you, thanks to Indocyan green. And this shows you how the segment 3 is important. So this is a very segment 3 after removal of segment 1 and 2. And you can understand, if you have some doubt, that probably the role of this remaining segment 3 is important for the pulmonary function. Then we staple south plane, always having an eye on the stump segmental bronchus. And this is how it looks like at the end. And again, this is a modelization 3 months after the segmentectomy, showing again that this segment 3 looks perfect. So that's all I wanted to show you as a practical application at the end. So in conclusion, I would say that these thoracoscopic segmentectomies are a really challenging procedure, but I think it's very interesting for us to have a new challenge. Mm-hmm. It requires to relearn the anatomy in depth, more in depth that we used to learn it before. Modelization is extremely helpful, especially for complex I don't see really any other safe way than performing a tissue-based approach to detect all the variations. Examination, examination of lymph nodes and margin is important in order to minimize keeping a positive lymph node or an invaded margin. Precisely determining the intersegmental plane is important, and the stapler must be used with care and in an appropriate way. So that's all I wanted to show you. There are many other points we could develop, but in 1 hour it was quite difficult.
Okay, so, very nice. Thank you very much. I had with this presentation of this case a few questions. Well, all are seem to be quite the same. Being if you take these 1 and 2 segment, the remaining segment 3, do you see any problems of torsion, twisting?
No, not with this segment, but it's true that it's a problem with other segments. We had at least 3 torsions of the lingula after segmentectomy. And so we are very frequently anchoring the lingula and anchoring also segment 6 after basilar segmentectomy when there is no posterior fissure.
Okay.
This is certainly something you have to take care, but we didn't face the problem with segment 1 and 2.
Okay. Another technical question was in one of the previous videos you showed us, these bulldog clamps, how do you place them?
We have a special bulldog applier. So that goes through a 12-millimeter port.
Okay.
And then we remove them.
Okay, perfect. Thank you very much, Professor Gossot. We are about 1 hour and 20 minutes, and a lot of people are thanking you, and congrats for this excellent presentation. I hope everyone has had the chance to have his or her questions, and we'll see you back within 1 month about mediastinal pathology with Professor Ruffini.
Okay.
Thank you, everyone. Thank you.
Bye.